Everybody for joining us. I see people still trickling in. We're going to give it just another minute and then we'll get started. Thanks for being here. Everybody, thanks for being here. Welcome to our Accords seminar series. Right here. So I'm Sarah Brewer. I'm the director of our Accords education program. Let me introduce you guys a little bit to Accords and who we are. So Accords is supported by the University of Colorado School of Medicine and Children's Hospital. It's a unique one-stop shop for pragmatic research and includes various types of services and support for grants and projects, along with incredible mentorship, training, and education in health services research. Accords conducts pragmatic research in real-world settings to improve healthcare and outcomes by providing a multidisciplinary collaborative research environment to catalyze innovative and impactful research, strong methodological cores and programs led by national experts, consultations and team building for grant proposals, mentorship, training, and support for junior faculty, and extensive educational opportunities, both locally and nationally, of which this seminar is one of our ongoing programmatic offerings. Coming up, we have a few more offerings. So first, as part of this same series in December, we'll have Jamie Stutz talking about basketball, bloodlines, bourbon, and Burley, community engaged research to change the lung cancer landscape in Kentucky. Starting in January, we'll begin our mini series on hot topics in mixed methods and qualitative research. And save the date for CopperCon, our Colorado Pragmatic Research in Health Conference, the first week of June. So that's June 5th, 6th, and 7th. Today, before I introduce our speakers, I just want to get everybody oriented. We have a couple housekeeping items. As we go through, please use the chat throughout the seminar to share any questions or comments. Feel free to discuss what our presenters are sharing. We'll have some time for moderated questions and answers at the end of their talks. So we'll be monitoring that, don't worry, and we'll bring questions at the end. And then second, watch for the evaluation link. We'll put that in the chat as we get closer to the end of today's seminar, but we really hope that you'll fill that out so that we can continue to be responsive to all of your educational needs and bring topics that are really relevant to your work. Today, we have Dr. Amy Huebschmann and Dr. Andrea Jimenez-Zambrano. And this is part of our methods and challenges in conducting health equity research this year. So before I hand it over, let me tell you how amazing these two are. So Dr. Andrea Jimenez-Zambrano, a native Peruvian, is an instructor in the Department of Pediatrics and a primary care research fellow at Accords. As a Latinx immigrant growing up in Colorado, she observed disparities in health outcomes across diverse communities. This experience inspired her to pursue interdisciplinary training in public health and social science through a double major in Spanish and biology, a master's in public health and community and behavioral health, and a PhD in health and behavior science. Her research interests include addressing health inequity in primary care through research that enhances the health and well-being of Spanish-speaking populations. Dr. Jimenez-Zambrano is a health and behavior researcher with over 10 years of experience in qualitative and quantitative methods and extensive experience in community-based participatory research. She has expertise in building capacity for qualitative data collection methodologies, including but not limited to training professionals for data collection, coding, and analysis for in-depth interviews and focus group observations. Dr. Amy Huebschmann is a primary care physician and associate professor in the University of Colorado School of Medicine with the Division of General Internal Medicine. The Adult and Child Center for Outcomes Research and Delivery Science, or ACCORDS, and the lead scientist for community education and outreach for the Ludman Family Center for Women's Health Research. She's the founding director and current co-director of the Graduate Certificate in Dissemination and Implementation Science for the University of Colorado Graduate Program in Clinical Sciences. In addition, she's the senior implementation scientist for several NIH-funded pragmatic trials, including this NHLBI-funded Decipher UG3-UH3 project to reduce pediatric asthma disparities. Dr. Huebschmann also serves as a co-director for the Network and Outreach Unit for the Colorado Implementation Science Center for Cancer Control and Prevention, and immediate past chair for the Education, Training, and Career Development Council for the Society of Behavioral Medicine. So, please join me in welcoming Dr. Amy Huebschmann and Dr. Andrea Jimenez-Zambrano today as they present Leveraging Community Engagement and Implementation Science to Reduce Pediatric Asthma Disparities. Welcome, Amy.
And Jordan's going to help me pivot slide decks here. Okay, well, it is wonderful to be able to talk to an in-person audience as well as my Zoom audience. I appreciate the opportunity to go through this topic with you all today. No relevant conflicts of interest for Dr. Jimenez.
Sorry.
Some technical issue. So do the Zoom webinars. All right. Does that look now good now? Okay. So as I was saying, we do not have relevant conflicts of interest to disclose. And to acknowledge it takes a village to do this type of work. We'll have a full acknowledgement slide at the end as well, but this just highlights our research team, our advisors, the coordinating center for the Decipher project and its technical advisory panel, and the relevant accords groups listed here. When we talked with Sarah about what the organizing committee wanted to see in this talk, it came out that examples of methods to improve health equity were relevant. And we should specifically focus on some implementation science methods as well as community engagement methods. And our objectives touch on that. The first one describing how implementation science methods could tailor to the local context across these social ecological levels. And then in terms of the community engagement, we'll touch on a couple of different aspects, understanding priorities for communities and also looking at differences in needs for programs amongst Latinx and non-Latinx families. So we'll break it down like this. I'll do the first piece with a project overview and the implementation science methods. Then we'll welcome Dr. Jimenez-Zambrano to talk about those 2 bullet points listed here. And then I'll wrap up with a few minutes on next steps and the discussion and question and answer. So put questions in the chat and we'll look forward to talking through them. I borrowed this slide from an earlier talk in this series and didn't want to take a deep dive in equity again because that you've already heard about that from the other speakers. Encourage you to review those talks. But just a reminder to focus ourselves that equity doesn't mean just having the same one size fits all solution or the same bicycle in this case for every person. We want to tailor the tools and resources to the needs of individuals and of groups to allow everyone the opportunity to be as healthy as possible. So that's where we're coming from with this. And we know that social determinants of health and structural determinants of health can be particularly problematic. And this project, Stop Asthma Attacks, takes those head on. This is also for those of you who are not implementation science wizards and are maybe relatively new to the field. So this cartoon is riffing off the idea if a tree falls in the forest and no one's there to hear it, does it really make a sound or does it make an impact? The cartoon itself is for marketing, but I'm going to take that parallel of research is really how we think about it with implementation science. So it says, if I write content, nobody reads it, is it really marketing? The analog would be if we have evidence-based research programs and nobody really delivers them or receives them, is it really making an impact? So the notion is we want to make sure that we're tailoring programs so that they can be used and can make an impact. This is a graphic that I'm going to walk you through from the upcoming 3rd edition of the implementation science textbook. I co-authored it, as you can see at the bottom, with Drs. Trinkley, Fort, and McNeil, and also Larry Green. And we think about this as it's not just something you do at the very end to get it to fit. You really want to be thinking about this from the pre-implementation phase when you're designing really evidence-based interventions themselves, and when you're planning how to implement them, when you are implementing them, and when you evaluate and sustain. It has to be considered across this life cycle of a research project. And at the bottom, you see in purple that really the more that we can have representation of invested partners across all three phases, that's going to help the most to have good equity and representativeness. Think about it being who's at the table. If we're planning things and those at the table are not those experiencing disparities, why would we expect it would really meet their needs well and be able to increase? And I put in blue here the notion of vetting with partners, the high priority problems, and what is success as some things that we're in particular going to hear Andrea talk about today. So funders are increasingly tuned into this as well, and this project is funded by the National Heart, Lung, Blood Institute, and NIH has taken a strong interest in implementation science. That I'm just going to touch on with this slide, their goal with this project, which funded 7 groups across the country to improve health disparities related to cardiovascular disease or lung disease, was that it would work with high burden communities. So it's going to not just take the people who would already be able to do this well and give them a program to do even better. They wanted to look at high burden communities, look at routine clinical practice or community-based settings to be delivering things, and test implementation outcomes like reach. How many people who are eligible for the program actually receive the program, in addition to effectiveness. Those are some of the key elements in leveraging implementation science to address disparities. A little more about our study. Since asthma is a common chronic disease, really the most common chronic disease of children, and disproportionately impacts low-income families, it makes sense to tackle with this type of work. And Dr. Zeffler and Sakuda with our team have really developed with others, including Melanie Gleason in the room, a school-based asthma program in partnership with schools and communities. And because of its very nature, has addressed social determinants of health, because that's really what was recognized would be needed to move the needle on care, and has been successful. Improved healthcare utilization, improved school absences, which is very relevant to the context of schools where we're in high priority outcome for them. Received this funding in 2020. The map of Colorado shows you 5 communities and regions where we are seeking to spread this program that was originally developed in the Denver metro area. I'll also show you a visual schema for the intervention and then talk through what its core components are, just so you can understand a little better how it relates to disparities. So the child and family at the top are certainly the focus to address asthma for the child. And then school nurses are really a public health sentinel. They have a child in school. They can see if there's issues going on with the child with regards to the asthma. They're coming to the office a lot, but they're busy. They're doing a lot of other things. So the asthma navigator is a community health worker who's able to come alongside them and work with the nurse-led team to help improve case management, asthma, and care coordination of social determinants. Very relational program. We know primary care or asthma specialists and also the social determinants of health resources and community are important to be coordinated by that navigator. This just shows the functions then at a glance that are happening across that schema to identify students with asthma, particularly uncontrolled asthma. Based on that asthma assessment that we identify those with poor control, and then make sure some things happen. A quick acting relievers on hand in school. They acquire self-management skills. Both the child and the family are important to that. And then tailored instruction to support the case management and care coordination, including social determinants of health. For this project that's funded by Decipher, I'm just going to at a high level give you a sense of the project, because our goal today was to tell you more about methods to improve disparities, not to just tell you all the nitty-gritty of our project. But its goal is to have good reach, so that's the implementation outcome, really get to eligible children with uncontrolled asthma and reduce the disparities for asthma amongst those students. The type 2 hybrid effectiveness implementation trial design, really in lay terms, just means it's important for us to look at the effectiveness. Even though this is an effective intervention, we're going to new contexts and new places we want to see it effective. And also to look at the implementation. Do our strategies gain good reach to obtain many students and families to enroll? Showed you the regions in Colorado and that it would be about 300 students who would enroll in total over the project. And the interventions to compare are the intervention alone with standard implementation strategies, or with an enhanced strategy of really engaging communities and schools for depth. We developed this in combination with our community's input, because we learned that this will help students and families want to participate if there's been more engagement. And that would enhance reach. Measures including reach are part of the REAIM framework, which we'll touch on in a minute. Reach is the primary implementation outcome. And we're also developing a website or dissemination guide to try to make it easier for schools to adopt this and sustain this. Just a visual of the enhanced school and community engagement and what that would look like within our schema that we were already talking about for the intervention. So it's working with the navigator to really enhance these connections between the child and family and the navigator and school nurse-led team by touching base with school influencers, parent influencers, community, social determinants of health. Now I am going to talk just a little bit more about the implementation science methods we're using, and especially ones that could be generalizable to other projects to address disparities. That includes frameworks, implementation science frameworks that I'll go through, both the processes those could guide, as well as how to use them to assess context or how you would tailor a program to fit the context at different socio-ecological levels. And then also, yes, the specific tailoring. So we're using a socio-ecological model picture here to think about our project in particular, and that might make it salient for other projects you're thinking of. So the individual focuses on the child with asthma, with uncontrolled asthma. And they have relationships that are important for this program, both with parent and caregiver, the school nurse-led team, primary care provider or other asthma specialists, and then the asthma navigator or community health worker. And we saw those relationships in that schema. There's also important organizations and what their policies and their characteristics could bring to the table, including the schools and the school districts, how rural they are, the communities themselves, how connected the primary care clinics are for the patients, and then what level and intensity of social determinants focused organizations we have in different areas. Those are just a few examples. Policy is also very important, especially related to reimbursement that could occur or other types of incentives or penalties that might motivate schools to want to participate. Implementation science models and theories and frameworks, there are many of them. At a high level, I'm guiding you through a couple today. EPIS stands for the terms you see at the top here: exploration, preparation, implementation, sustainment. And we're using it in particular to guide us through these phases of a project, of the life cycle of the project, and thinking about how our partners need to be involved across those phases. So in the first phase, we're understanding from community, from schools, primary care, their needs, priorities, and resources. We'll touch a little more on that in a moment. And then in this preparation phase where our team is at right now, we're really developing interdisciplinary partnership with community. Again, thinking across these different levels. Then when we get to implementation, we will be implementing the Stop Asthma Attacks intervention with or without that enhanced strategy and assessing it, and then looking in the sustainment phase, how to leverage partners' financial and logistical support to keep the program going in the long term. As we assess the context, we're really thinking about it with the expanded REAIM framework. Many of you may be familiar with the REAIM outcomes at the bottom of this slide: reach, which we've already talked about, effectiveness, adoption, implementation, and maintenance. But you may be less familiar with these contextual determinants at the top, which I'm just going to talk you through momentarily. For the intervention itself, the perspective on the intervention matters for both the patient, child, and family, as well as the organization, which in this part, we're thinking of schools. Organizational perspective primarily, since they're the ones who need to adopt this. And that happens at different levels, as you can see in the circle here. In addition, there's characteristics of both the patients, child and family, and of the organizations that need to be considered. So we have dove into those things during the exploration and preparation phase. Finally, this external environment is very particularly relevant to those policies and reimbursement that could be leveraged for the program's success. Yes, in the exploration phase or first phase, we did work with the WHO listed in this slide to understand these elements of PRISM that I just talked to you about, with a focus in particular on what I've listed here on this slide, notably the readiness for change for schools to understand how ready they would be to adopt this program, as well as the things we already mentioned. And then in the preparation phase, we're moving on to plan and develop and build the capacity Dr. Jimenez-Zambrano is going to talk about these outcomes of success in just a moment. And then the co-development has been occurring of general implementation plans, and then looking at how we tailor those plans for different contextual factors in our regions. And we're continuing to update and make those more easy to access by getting elements of those into the plate. So I'm going to pass here now to Dr. Jimenez-Zambrano to go through the next set of slides.
Sorry. Thank you, Amy. Sorry, in the wrong way. So I'm just gonna talk about our Decipher team and our community partners. And we'll start by talking about the principles of community-based participatory research that we are using in order to build effective community partnerships. So inclusion and diversity of voices. I'll be giving more information about our CAP composition, but our CAPs are trying to hear every perspective and be inclusive. Building on strengths and resources of communities. A lot of the interviewing and the brainstorming that was done with the community advisory boards was trying to understand community strengths as well as resources, priorities, their perspectives, and how they relate to this program. Also sharing and discussing results and plans. We are talking to our community advisory boards. We're sharing what we're working on. We are talking about results. And then when I go over our priority outcomes, you'll see how involved they have been. So what is our Decipher engagement model? We have 5 different regional CABs, and you can see here how rural they are. And we also have a state community board. And in this community board, we also have one or two members from the regional CABs that are part of this board. And this state community advisory board also have more representatives with who care about state priorities. These CABs meet quarterly. They also are paid for their time. I think it's really important for community members to receive compensation for any work that they do, and for us to recognize that their time is valuable and their expertise, and we need that from our projects. And some people, as part of the CAP, might not have been able to get paid because of their position, but we do our best to pay everybody. And as far as the composition of the regional CAPs, I'm bringing up the map again so you guys can see where our regions, our 5 regions are. But 93% of our CAP members are females. 49% of them are healthcare providers. 23% of them are school nurses. 20% of them are parents, and 8% of them are from social determinants of health agencies and local public health agencies as well. So let's talk about some actual methods. So for priority outcomes of success, as part of our planning phase, we focused on understanding what success of the project will look like for 5 of the regions that were shown in the map. And we consider success across 4 domains as listed here on the slide. And for this presentation, I will focus on the methods that were used to build consensus and the outcomes of this process for the 2 bolded categories here, which are schools and social determinants of health. So we used nominal group technique, and this process moves across these 6 elicitation stages. So the initial process was the generation of ideas, and this was conducted but this happened by doing qualitative interviews and brainstorming sessions with CAP members. All of the ideas were recorded. And then for step number 3, each CAP got to review all of the ideas that were created by all of the different CAPs. So it was a pretty large list. And we asked our participants to do some preliminary voting. As you might think, if you have a list of 20, it might be hard to just narrow down to 2 or 3. So we did some preliminary voting. And when voting, we asked participants to focus on what could be feasible and what could be accomplished within this scope and resources available in the program. And then we did some more discussion after that preliminary list was generated. And then we did final voting. And like I said, we asked each regional CAP to come to their own top 2 to 3 priority outcomes in each of the categories. So now, just some results. For the school domain, I outlined here in blue at the top, we can see the letters A and B, and those were the top 2 priority outcomes of success identified in the regions. You can see here that there was a good consensus from all 5 of the regions. And by looking at these outcomes, you can see that it reflects the need for better coordination and connection between the schools and the healthcare providers. And for those of you that are a little bit less familiar with asthma care plans, when a child has asthma, in order for them to have an inhaler at school, the parent needs to complete an asthma care plan that needs to be signed by the healthcare provider. And that allows also the school nurse to be able to talk to the healthcare providers. So that was a priority, making sure that asthma care plan is on file. And also by having that on file, we're able to increase the connection between the schools and the healthcare providers. So that's really important. And at the bottom, we see the outcomes of success related to community and social determinants of health. And you can see that there was a little bit more diversity across the regions. There was also some intersectionality between priority outcomes. So for example, 2 out of 3 outcomes here are related to literacy and the need to address literacy not only for the parents, but also for the child. And we see transportation, which you can understand in rural communities, transportation is key. So in summary, using nominal group technique as our consensus building approach allowed us to work with 5 different regional CAPs to identify what outcomes of success will look like in each of their communities. And we were ensuring that we were hearing their voices and what they thought was important. Also, by doing the process of interviews with CAPs, doing the brainstorming sessions, like I said, we learn more about what their needs and resources are. And by engaging them in the nominal group technique process, we learn more about what success of the program will look like for each of them. And by doing this, we could tailor how we implement the program and what strategies we use to ensure that we're overcoming any barriers that might prevent participants from engaging with the program. And our results are a great example here of the intersection between implementation science and health equity. And as you guys saw from the process, this is a process that can be replicated in other studies, and you are engaging community and learning more about what their needs are and their priorities. So now I'm going to talk about a different project. So about 18 months ago, I approached Dr. Stan Seffler and I asked him to talk to me about what his concerns were on disseminating or on implementing this new program. And he said that he would like to hear more. And he was concerned that we were not hearing enough from the families and what their needs are and how the program will be received from them. He's also been hearing from the CCTSI dissemination team that they wanted more information about how we can make this program appealing to them, how we can engage families. So this project was born from that discussion with Stan. So the objective of this project was to understand more of the barriers and facilitators that might influence the family's engagement with the Stop Asthma Attacks program. And the second aim was to identify any possible adaptations to the program, just to make sure that the program was going to be acceptable, accessible, and was also going to be culturally tailored for these families. So the methods that we used was we conducted semi-structured interviews guided by PRISM, which was a framework that Amy mentioned and talked about previously, and also Cooper's health equity work or health equity framework. And we use the health equity framework just because it addresses in more specific some of the barriers related to health equity. So I just wanted to show it here. And our interview guide was developed based on the constructs in both of these frameworks that you might see that overlap in different pieces of it. So like I said, we conducted semi-structured interviews. Participants were recruiting from 2 of the 5 areas, the Greeley-Well, Fort Morgan area and the Lower Arkansas Valley area. These 2 areas were picked because of the CAP's concerns about how we were gonna tailor the programs to the Latinx community. So we decided to use these 2 areas. Participants were recruited from Salute Fort Morgan and also the High Plains Community Health Center. Inclusion criteria included speaking either English or Spanish, live in one of these 2 communities, and be the parent or caregiver of a child between 5 and 12 years of age. So now I'm going to talk about some of our preliminary themes. A total of 22 interviews were conducted. Some of the barriers that we encounter was just the fact that there was a lack of education about asthma and how to manage it, and that impacted how children were taken care of and what parents were doing for their asthma. Both rural locations describe similar experiences with primary care providers and emergency care usage because of the limited availability of primary care providers. When a child was having a flare-up, most of the time they would just go to the emergency room because they couldn't see their provider that same day. And some of the facilitators that we found was that all of our participants were open to taking part of the program. They said that they needed and were open for more information and that everybody that had a child with asthma should take part and learn more. And as far as tailoring to fit, we learned that the school involvement in asthma management was strictly related to how parents perceive their child's asthma severity. So if the child thought that if the parent thought that the child was going to have an asthma attack at school, of course they were going to have an asthma care plan on file. But on the other hand, some people that might be qualified as severe asthmatics, or that might, a provider will say they have severe asthma, the parents didn't thought about it that way, so they didn't engage as much with school asthma management. And the second theme was that language barriers really did have an impact on how parents manage their child's asthma. If the parent couldn't speak English, their understanding of the diagnosis was critical. They didn't have access to medication, and they really had a hard time communicating with providers. So I am gonna let Amy talk about next steps. Thank you.
Thank you, Andrea. And you noticed that we took you on a whirlwind tour there with those, but really wanted to give you a couple of different bites or tastes of different methods to address health equity. So in showing you where we're at on our current timeline with the study, the upper left shows where we're in the UG3 phase, which is the planning phase of this trial. And then we're working with NHLBI to apply to go forward to the actual trial itself, starting in September of 2023. You can also see at the top with the EPIS framework how this fits with those different stages I showed you earlier for exploration, preparation, implementation. And in the bottom left, you can see what we're doing right now is collecting baseline data for the study from our different sites. And these are randomized trials where the school nurse and their schools are randomized to get the certain type of intervention condition, but then we are doing individual level consent and getting data in that sense as well. And then in the UH3 year 1, 2 of the schools in regions will still have a control phase or baseline data collection phase, and then other school nurses will be randomized to the intervention condition, either the standard strategy or enhanced, as we talked about earlier. And then all schools will be randomized to one of the levels of intervention by year 2 of the trial. They'll be in those same tracks for year 3 of the trial. And then in year 4, school nurses and schools will decide, can they keep doing this? Will they stay with the track they were assigned to of standard implementation strategy? We'll be discussing the findings to date, and some schools might swap and say, we want to do that enhanced strategy. We can still do this. Other schools might say, we aren't able to do this. This is too much for us to sustain. We'll track all of that and also look to understand the PRISM contextual factors that predict these decisions. This just gives sort of a checklist as well as some of the things that we're doing to finalize our protocol for sponsor approval and get all of our nurses recruited and get data collected. Lots of things to do in this planning phase. And this just shows some school nurse recruitment totals and the success we've had so far. Across 4 of our 5 regions, we have had success with schools and school nurses agreeing to do this. In the Montezuma-Cortez area, it was really difficult. Some post-COVID challenges persisted, and it was harder to engage with schools there. But we are looking to enroll them and engage them in existing additional Colorado Department of Public Health and the Environment grant that Stan Zepler has to continue to engage that region and bring them along. They just couldn't move quite as fast as our other regions. So just touching on a couple of key challenges. One has been obtaining actually sufficient finances to include all eligible and interested schools across our regions. That's turned out to be difficult, particularly with some of the requirements that the funder has asked us to do in terms of the study design. So we are seeking out actively supplemental funding. We have some foundations on our state advisory board, but also welcome people to reach out to me if our talk today has spurred you to think, you know, I know a group that has a mission that this is very aligned with. You should talk with them and see if they might want to help co-fund what you're doing. And we need to find those types of sponsors for the sustainment phase as well to help continue this program to flourish after the groundwork we're laying. And then also to not let the cart get ahead of the horse. Our primary outcome is implementation outcome focused in terms of reach. And that's what the funder really wants us to show that we can move on. But we are also very interested and think it's really critical to also look at the effectiveness of the program in these different contexts. I'm going to give credit to our team and our advisors. Listed out the members of the team here, and I also have slides to show different members. Andrea gave you a listing of just the general types of roles, but these are our advisors for the Lower Arkansas Valley CAB, and then for the Greeley Weld Fort Morgan CAB, you can see there are, as Andrea said, both healthcare providers, school nurses, members of community as Pikes Peak and the Mesa Delta County. So at that point, we're ready to pivot over to questions. Of Andrea come up with me. Oh, and we have the reference for our publication that does have some additional details about processes with the study as well.
For me on the mic here. Yeah. I'm not hearing it come through. All right. Yeah, I'll just come up here. So we've got a couple questions in the chat, so I'll relay. The first one was about identifying community strengths and how you did that in the process and when you fit that into all the planning that you've been doing. You talked a lot about needs, but what about strengths?
So in terms of the strengths, this was, baked into the grant that in the exploration phase, we would seek to understand strengths both from schools. So all the members of the community advisory boards, we built our boards in part based on some of the groundwork actually that the team had done, engaging with other communities around the state through the Colorado Department of Public Health and Environment grant that Dr. Zepler already had. And then with those CABs, we purposely did interviews with them, seeking to elicit strengths that would, we talked about what the program was and how it operated, and then sought to understand elements of their community, their school, intersecting priorities and resources they already had that could be leveraged. So the timeline was from the beginning. In terms of child and family interviews.
Yeah, I mean, for child and family interviews, basically we talked about just their lived experiences and how they were managing their child's asthma. And I think one thing that really came through was just the fact that most of them had a primary care provider and they were aware of an asthma diagnosis. So I think just by engaging and talking to them, they is how I got to strengths and just building rapport with the community. We did I did all of the Spanish interviews. So I think there was some rapport in the fact that I was able to speak the language and just relate to them, and they were happy to share their experiences with me.
Again. Does that sound better? Give up on the hand mic. So the other question, we've got a couple people in the chat asking about the Cooper's model for health equity. Can you talk a little bit more about how you used that, how you applied that for your interview guides, how that guided your work?
Great question. Well, I found that great health equity work by talking to my collaborators who have been using it for many, many years. But basically, and maybe I can pull up the just a slide so you guys can see it here. But oh, sorry guys, this is painful. There you go. So basically, what I did was just look into the framework and just look into every construct that they highlight as important for equity, and then design questions around that. So for example, if I wanted it to, look or learn more about language, I did ask a specific question related to racism and discrimination, but it was interesting because people did not share as much when I asked that question, but when they describe their experiences, they share all of that. They share all the barriers and everything that was related to culture and attitudes, and just by listening to them. I think listening to them and knowing when to ask more questions and making sure that your guide is, kind of trying to touch into or addressing all of these barriers in some way, shape, or form. So when I was looking into, for example, insurance coverage, I will ask, I'll ask what type of insurance does your child have, and then, how is the coverage? But again, by learning more about their experiences and listening to their story, things just come up. Yeah.
Another question, I think mostly aimed at you and some of the things you talked about at the beginning, Amy, around the implementation website guide. And if you could talk a little bit more about that and how you've used that and the resources that are available there.
Absolutely. And so the guide is live and on the web. So you can look at coloradokidswithasthma.org and see it. Maybe Jordan, you could put that in the chat, Colorado Kids with Asthma all strung together.org. That process looked like hearing in our exploration interviews how people would want to access information in the schools for school nurses in their everyday to be able to use some of the resources for the program. And we also engaged with a human-centered design and web design firm, Aclaro, because we knew their expertise would be important for having usability on the web and to not just know what people needed, but how to get it in a quick fashion on a website or on an app. At first, we didn't know if it should be a website or an app, and talked with people about that and what the school nurses would want and would use. We heard a lot about parallel websites, like one called coloradokidswithdiabetes.org. So that helped us think to title ours coloradokidswithasthma.org, and to think through the different segments of the site. That the site would be landed on by family members and children, or they might want to, nurses or navigators might want to send materials and resources from the site out. So it became a notion of keeping a clearinghouse of resources there and then organizing them to be usable for our different participants.
I'm going to repeat that question for those of you who are still on Zoom. She's bringing up that at the beginning of the presentation, Amy didn't use the word stakeholder, but talked about all the partners that we had. And so, Amy, can you talk a little bit more about the terms you used and why you chose those terms?
Yeah, absolutely. Yeah, yep, exactly. Well, and so I borrowed from the CDC. So the CDC has a website where they say alternate synonyms for maybe classic terms we've used in research, but with the vestiges of colonialism having still some negative connotations for the word stakeholder, they have a few different synonyms, but invested partner was my favorite one.
That the comment was, can we get that CDC link in the chat? And Amy's going to work on pulling up the guide from the CDC that has a number of different terms for different kinds of invested partners or community partners by different categories. So we'll get that shared. Thanks, Jordan, already. Do you have any other questions here in the room or on chat for our virtual attendees? So the question is, how did you guys get to such a big team, and what instigated that?
Yeah, great questions. Well, the team, which I'm getting to that slide, was really almost this big when we submitted the grants, to be honest. It is, since it's a U award, it's a little bigger than even an RO1, and we had a very ambitious goal, still do, to reach all these regions. Many of the other Decipher projects are seeking to do things in like one city, whereas we really tried to take on different segments of the state. So we felt like this team was needed to be able to get to that. So our segments were asthma experts and community engaged research around asthma experts, which is Stan and Lisa, myself with implementation science, obviously need a biostatistician. And then we have Lisa DeCamp with general peds and health disparities research. So beyond this asthma specialists, needed to also have people representing the primary care lens. And then Arthur McFarland was a social determinants of health expert. Important to have him on the team. Can't do this without mixed methods and qualitative. I will say Nikki Wagner joined a little later because we realized the implementation science aspect was so big that I couldn't do it all alone. So we had to build the team in that regard. And then of course, you can't do things without project managers, coordinators, and qualitative analysts. So I'd say that this was the original team for the most part. And we do have a few other people not shown here. Maybe to the point of building the team, we brought in trailheads, which we were hearing about in the early qualitative interviews, was an important convener of influencers in different regions, and that we would need that to think about sustainment. We would really want to look at how trailheads might be able to sponsor in the long run things like the community health workers and navigators. So we brought them onto the team a little later, to your point.
Other part of that question was about pilot data and how that influenced our team and maybe is influencing some of our the longer term plans for the project.
Yeah. I was just having a sidebar part of what we realized is we needed certain elements of pilot data. The grant had set out these different elements of the socio-ecological model to get pilot data about in the exploration and preparation phase. And then we realized there were maybe areas that we had not initially proposed to do as intensively. Andrea gave that origin story, and really it was part of then how we brought her in. She's not shown on this slide because we brought her in as part of her primary care research fellowship project when we said, ooh, this is a gap. We need more on this. It would be a good fellow project. So we were able to obtain pilot data in that regard for that group that wasn't otherwise going to have as much data collected in the standard exploration phase as we had originally. The other pilot data were kind of on the slide for E for exploration phase and preparation phase, largely surveys and interviews to look at elements of those PRISM domains to really understand the context for tailoring.
I think we've covered everyone's questions, which is a rarity. Thanks for giving us time for question and answer. So I just want to remind everyone, we have a few more events coming up. So watch for Jamie Stutz in December. And he'll be talking about lung cancer program in Kentucky. And we plan to be in person again. Come have lunch with us and hear Jamie live in person. And then watch for our mixed methods series coming in January. If you have not yet, please complete our evaluation. The link should be in the chat. Again, that helps us make sure that the educational programming we're providing is meeting your needs as attendees. And finally, thank you, Amy and Andrea, so much for a wonderful discussion of your Decipher planning project and grant. Thank you, everyone.